mama still stuck back there. Come on out of that cave. Come on. You can build your own house. There is liberty. Don't you know? Have you heard? You have been set free. We are free thinkers. We're free. We are free thinkers.
Greetings, greetings, greetings. Welcome back. We're glad you're here. This is episode 11. Where has all the time gone? Look like I just started this yesterday or sometime. It's going fast, but boy, am I having a ball. And I'm so excited. You know, I just want to interject this. Our show, this episode on the Creative Motion Network on Roku, our first episodes out of the top 10, we were number 1, 2, 3, and 4 a couple of weeks ago. So to God be the glory. I was like, wait a minute. So out of the top 10, we were the top 4, and there were the episodes. And I just found out last week as well, is that there are followers from all around the world that are following this podcast. Because of Roku, you know, you got streaming live. So there are some regular followers and it's growing. So I am so grateful for that because my whole heart when I wanted to ever do this was to provoke thought, bring awareness, and point people towards intervention. You know, and so all the topics that we talk about, that's the whole focus of what's in my heart because people are suffering and they don't have to. They don't have to continue to suffer, which brings us right into what we're going to continue to talk about here on episode 11. We have this amazing woman who I have so much respect and adoration for, Dr. Heather Gillum. Is with us again. She was in our last episode 10, where we were talking about the difference between disordered eating and eating disorders. We talked about a lot of different things, you know, how I kind of go. I kind of go in and out in different places. But these are good things that provoke thought. We want to provoke thought, bring awareness, and point people towards intervention. So we talked about a little bit about trauma in our last episode. We talked about culture. We talked about the difference of body types and different things. But this episode, we're going to get a little more specific. When I worked in I worked at a psychiatric hospital. That's where I met Heather. And that particular hospital had an eating disorder program. And I was like, wow. That was a whole different area. My thing was, give me an alcoholic and a drug addict and I can just go all day long. I love working with addiction disorders, alcohol and drugs, and mental health as well, because they kind of go hand in hand. But the eating disorders, I was like, Lord, now that's a whole different flow right there. I don't understand. And I said, please help me understand. So I began to read, explore, research, ask questions, because I saw people that were so broken and just skin and bones, from that to people who were 600 pounds. And it was like, okay, wow. And so I just saw such a variability. And so we just want to provoke more thought. We want to bring more awareness, and we want to point people towards intervention. And having said that, Dr. Heather Gillum, she is one of the resources that is on my page on www.janicepons.com. I have a page on there that says resources, and you can just click and get help for any and everything from finding a therapist to a support group if you need inpatient therapy somewhere. And Dr. Gillum's specialty and her expertise is in eating disorders. She is just a wealth of knowledge and just has so much to offer. And so I'm so honored and blessed to have her back as my first guest. And so we're going to dive right in. Last time we talked about, well, we're going to get a little more specific this time. We're going to talk about actual eating disorders. So, I don't know how many there really are. Like when I think about your major mental illnesses. It's like major depression. There are certain ones that insurance companies are looking for: schizoaffective, psychotic disorder. You just have your categories that are your major ones, and there are some that are not major. Like people will say to me, what I do, I advocate for people that can't advocate for themselves to get them authorized for more treatment. And then a therapist may look at me and say, well, we need to get more days authorized. I said, well, based on as evidence by what? You got to give me some data to work with. They said, well, they're anxious. I said, the insurance don't care that they're anxious. They they care, but that's not going to get us more days authorized. The fact that that they're anxious, because everybody's got some kind of anxiety going on. We got to have a little more. It's got to be major depression, schizoaffective, bipolar disorder, psychotic disorders. When you're talking about mental health, and so the same with eating disorders, there are specific ones that are your major ones. I'm believing that insurance companies recognize as major disorders. Let's go there a little bit. I want you to have your liberty. Go ahead.
Well, thank you again for bringing me back.
Uh-huh.
I could jump on this soapbox really quickly, and God bless those insurers and ethical reviewers that are doing their job to really support their patients in care. But there are different categorizations and classifications of eating disorders just diagnostically, and then under each one there can be a specifier. So for example, anorexia nervosa, there are things that are just hallmark symptoms of that disorder, but there can be a purging type, there can be a restricting type, there can be mixed types, and that's the case there. The specifiers go on and on for a variety of illnesses, but insurers often tend to prefer to avoid paying more than they would have to, as we know.
Mm-hmm.
And at the end of the day, they'll usually pay for somebody who's severely underweight, right? Like there is a strong compromise in terms of their organ functioning. I mean, this becomes very critical. And to be fair, anorexia is the leading killer of young women ages 16 to 24.
Wait a minute. Say that again.
Anorexia is the leading cause of death for young women ages 16 to 24.
Wow.
Yeah.
That's something to pay attention
all
to.
of the other reasons that young women in that age bracket would die. Anorexia, I mean, it's a life-threatening illness, right?
Okay.
But
wow.
what we know is that there are other types of eating disorders that are lethal in their own way, and that may or may not show certain types of medical, as they say, medical or organ compromise.
Mm-hmm.
And so when it comes to things like binging behaviors or bulimia, things like that, sometimes insurance doesn't want to pay. They don't want them to be there that long. And so it's really important to find the right care quickly, because sometimes insurance will push them out. I think that the piece of that makes sense is that people that are struggling with overeating really need access to food so that they can go through the process of exposure and response prevention, kind of a method of treatment. And they have to have access to it, where if you're in an inpatient setting, then ultimately the food is controlled, it's provided for you. And so it's not the same thing as having a pantry in a dark house at midnight where you could go binge. And so there are treatment programs that that provide certain levels of care to kind of support that even in an inpatient setting. And so I developed a method for that for inpatient, to do battle and fight for these young women to have that kind of care and the time that they needed to create abstinence from behaviors in the hospital.
Amazing. That provoked so much thought for me, everything you said. So with anorexia, that's the one they're just they're just losing weight, they're emaciated.
Yes.
We'll authorize that. And so what do they normally offer? It's like they'll give you 2 weeks, they'll give you 30 days. How does that normally work?
It just depends. Right? It depends on the severity of illness.
Yeah.
It depends on the severity of the behaviors.
Okay.
How much weight do they need to restore?
Mm-hmm.
Once somebody has been restricting, is the term that we use, for a long time, then you can't just turn around and feed them everything that they need, because their liver has not been processing things, their stomach has not been processing things. So the body can go into a little bit of a difficult process in what we call refeeding. And there's actually what's called refeeding syndrome.
Talk about that a little bit.
Well, I'm not a physician, so
Okay.
I'm probably not the best
Okay.
consultant. But think of it just the liver. Let's just break it down into the liver. So the liver is a filter, right,
Right.
within the body. So if you've not been providing your body with enough nutrients or nutrition to keep the liver working actively, then the liver can maybe get a little lazy, if you will. It's not having to process a whole lot.
Right.
But then when you hit the body with all kinds of variety of nutrition or a higher volume of nutrition that somebody who's been restricting severely has not been having, the liver's like, whoa, what's going on? You're hitting me with too much. And so then you'll start to see elevations in liver enzymes and things like that.
Right.
And there are a variety of other symptomatic features dealing with different organs in the body that would be an indicator of refeeding. And that's part of the reason that the inpatient treatment is so important when people are going through a distinct nutritional change, whether it's in their weight, their intake, how they're responding to food. Those things are really, really important to deal with in an inpatient setting, so that they can be monitored medically, so that they're not, further compromising their body and their efforts to get well.
Wow. Anorexia nervosa, like I said before, the first time I heard of that was with Karen Carpenter, the Carpenters. They were just such an amazing sound and singing in the 70s. And then she died, and it was just, I was stunned. We were stunned at school the next day. What is that? We just didn't know what it was. And it was such an eye opener. So anorexia, from a payer source perspective, insurance companies, they have to decide if they're going to authorize treatment for something, and so that's one that they'll more readily authorize. Anorexia nervosa.
Yeah.
Okay. What's another one?
Another one would be bulimia.
Talk about that a little bit. Bulimia.
So bulimia can have can turn up in a variety of ways as well. But again, getting back to the idea that when people are struggling with binge eating, that can be part of bulimia, and binge eating can be its own separate disorder as well. Then a lot of times, to get better, they've got to be able to have access to food and to be able to kind of manage their response to that, right? To have access, but to not go there and not go into their binge cycles and things like that. So there are ways that can happen on an inpatient level, but with anorexia or with bulimia, there can be patterns of purging, right, and undoing, whether that's excessive exercise or whether that's vomiting, or there are a variety of ways, taking laxatives, things like that. So these things can create remarkable compromises in their health very quickly. And so we're seeing, and over time, developing more ways to provide that kind of care and advocate for the level of care that patients need to be able to have, again, that experience of exposure and response prevention.
And amazing. I remember when I first got exposed, my specialty was working with those that had addiction and alcohol and or drugs, and combination of mental health as well, and the eating disorder program. I mean, I would just see these young ladies just sit there and agonize over eating. It was just like grueling. I mean, they just take it and pick a little piece over. And it was, I mean, they had to have medication to help with anxiety to be able to eat. Just so many various presentations, all centered around food, the fear of food, the purging, putting them on what we call purge precautions, which was after a meal, they had to sit in a designated place for 45 minutes and really actually have to be watched because they had a propensity towards purging and getting rid of the food. And then the body imaging and the dysmorphia, and it just went on and on and on. I was like, wow, this is an entirely different flow that I had never seen.
Yeah.
So it was an eye opener. So you have anorexia nervosa, the bulimia. What else?
Binge eating. Sometimes people can struggle with binge eating in the context of bulimia, but without undoing behaviors, right? And so these episodes
go there a little bit with the undoing. Kind of dissect that a little bit for us.
So, and this is where the family comes in, honestly. Really, really important to get the family involved in this, because you can ask them, what happens after dinner time? Where are they? What goes on after dinner? What is your family doing? Well, they go off to the room or whatever. And then when they really start looking at those patterns, they might see somebody that is purging. They might find somebody that's going and doing all of this excessive exercise, or, they've found some way to kind of hide food depending on how they're struggling with their illness, and, getting rid of the food some other way. So there can be any number of things that go on for undoing.
That's
Again,
the undoing.
the laxative use, things like that, when they're wanting to avoid gaining weight.
Okay. So, anorexia nervosa, bulimia, binging.
Yeah.
Any other category?
There are some other categories. ARFID, avoidant restrictive food intake disorder, and there can be, just different types of eating and feeding disorders that we often see in earlier childhood. We see a few of those patients on an inpatient setting, but not as common as anorexia and bulimia.
What do you see with children? Just kind of touch on that a little bit for me.
Well, this is where the genetic component comes into it, right? So how they experience their sensory experience of food, taste, texture, things like that can come into it and really make a difference in their experience of food. If they've eaten something, they didn't like it, had anxiety that coincided with that, just our brain makes connections, neurons that fire together, wire together. Not my original quote, I'm borrowing that one. But that's what happens. And these kids struggle with different kind of neurological experiences of food.
That's interesting. I've seen scenarios I can remember seeing just growing up. Kids get pressured into eating. Eat now! Hurry up! And they're trying, and they just get in a tailspin just about eating and eat everything. And it's like, oh, okay, wait a minute, something's just not right about this pressure that I've seen put on children related to eating. Well, you need to do it, but it's like this dogmatic hollering at them, and it's all centered around food. And I'm like, this is not good.
Yeah.
I just don't see how this is going to turn out good for this baby. Yeah. Talk about that a little bit.
Yeah, it doesn't go well. I mean, a lot of times when patients are finally reaching us, right? It's not uncommon for us to hear stories of families saying, like, why don't they just eat? Or grandparent, again, because we know more about eating disorders than we did 10, 20, 30, 40 years ago, saying, why don't you just eat? They just need to eat a hamburger. And it's not that simple. It's very strongly based in anxiety, right? And so, a family's pressure can be in their own stress, their own anxiety, right? Apples don't fall far from the trees, right? So in their stress, their worry for their loved one, they can be pushing them. There can be expectations, culturally, again, within family dynamics, and expectations at the dinner table that can add to that level of stress and anxiety. But yeah, we've not usually found patients to be very responsive the more pressure you put on them.
So with children, I mean, what's a common sense approach? What would you say? We parents do some jacked up things sometimes, and they don't mean to, but I was trained as a psychologist, a school psychologist. You're trained as a clinical psychologist. I took some classes in graduate school at UVA, University of Virginia, with clinical psychologists, and we have that mindset of what's dysfunctional criteria, categorization, that kind of thing.
Yeah.
But common sense, everyday functioning, what are some kind of guidelines or things to think about as a parent as it relates to food with our children?
Sure. Well, I think it's important. I mean, the pace of life has, just been a little wild and back and forth, right? Life is too fast. And then the pandemic has had us all slowing down remarkably, but that's created a number of stressors. And so that's a whole nother thing altogether. But having family meals together is really important. And I think that's something that sometimes goes by the wayside, and then parents are unable to see what's going on with food and their kids. So that piece is very important. But making that dinner time quality time together, creating as low stress as possible. Some families will sit down and they'll be doing the things that a lot of our patients are like, don't make us do high-low at the table. Don't make us tell you about our best moment of the day, or, worst moment of the day.
What's high-low?
High-low, my high for the day, my low for the day,
Okay.
Yeah. Kids are too smart for that, but it's a good thing to do, right? That they'll gripe about it, and then 30 years from now, they'll thank you. But these types of dynamics need to be happening so that they're developing a common, healthy relationship, both with food and with family. And if there are difficulties, families are seeing it.
Wow. I'm chuckling And here's why I'm chuckling. Okay, I'm gonna go there because in the Black community growing up, we were just trying to survive.
Yes.
And we didn't talk too much about the high lows. Y'all know what I'm talking about. See,
Mhm.
some people listening, you say, what they talking about high low? Because I'm a trained professional, right? But what you talking about? High low. Okay. It's just that's interesting. I like it though. It's a way to structure how our children can think.
Yes.
To provoke to elicit conversation, because one thing that's not happening, people aren't having dinner as a
No.
family at the table.
No.
Everybody's eating on the run, or you grab something, or we do not have the dinner time at the family dinner time at the table like we used to. And when my son was growing up, that was something that we endeavored to do. We're going to sit at this table and we're going to eat as a family, and we're going to enjoy together, pray together, eat together. And that's something that's just gone by the wayside.
Yeah. And it may not be realistic every night, right? I mean, in reality, it may not. But the more emphasis that you can put on connection, and this kind of maybe gets off again into a little bit of Heather vision, but in my years of working with people with eating disorders, what we see underlying, right? We've got the genetic stuff, we've got the anxiety and stress, but what it comes down to when it comes to healing, when it comes to wellness, all of the scientific interventions, the things that have to go on, whatever levels of care they need, I have yet to ever come across a patient that did not need connection.
Right? Talk about that a little more. Connection
with family, connection with friends, which is another reason why this pandemic has been tragic for people that struggle with their eating in one way or another, because the isolation has become very difficult for people to deal with, right? These behaviors usually happen in secret. They're pretty covert.
Wow.
And so finding that connection, it's within the context of relationships that people get well, right?
Yeah.
And having that accountability for themselves, to have connection and that validation, and along with that connection, the identity formation. When we start talking about young people and their struggle with their view of themselves, their view of their body, then you're talking about identity. And it's in connection, in healthy connection, that they find out really who they are, right?
Wow. That's why I push and push and push. And you know this, I talk about recovery support. And people a lot of times, well, I don't want to go to any meeting. Well, I'm going to tell you what, that's where Janice found herself. A part of my soul got healed when I went to Al-Anon. And I had a professional to tell me I needed to go to Al-Anon. I'm not going down there. I don't have a problem with alcohol. I used to, I drink because it was social. Everybody was drinking back then. But I don't need to go to Al-Anon. She's like, okay, well, you don't have to go. But I'm telling you, when I went every week for 6 months, and I got a sponsor, and it's one thing to go to the group, the support group, but it's another thing to actually work those steps that really just took my soul, my mind, my emotions, my intellect, my drive, my desires, my understanding to an entirely other level. Recovery support, because I got a sponsor. And Al-Anon is for the loved ones of those that have a drinking or addiction issue. And I was like, all of mine are dead and gone. She said, but you're still affected by what's going on. I need to take a look at that. I'm gonna go show up. I'm gonna try it. I walked in. It was professional folk that I knew in there, and I was like, wow. Okay, let me just sit here and listen. I was blown away. One of the best things that I could have ever done. The Holy Spirit met me front and center right there in that recovery support group. So what you're talking about, that connectedness, it is so vital. The accountability, others that are having the same struggle. It kind of, what you may be dealing with, what we may be dealing with isn't normal per se, but it normalizes it in the sense that I'm not the only one dealing with this. And this is something that the church has stayed away from. They don't want to talk about. They don't, I did that one on pornography and the church. They don't want to talk about it, but it's rampant. Addiction is rampant from the pulpit to the pew. We have ministers, very anointed, strong call of God on their lives, and they end up overdosing or committing suicide. And it's so unnecessary. Suicide is it's not that people, everyone I've ever worked with who attempted suicide, the first thing I ask them, I said, let me ask you something. Did you really, really want to die? And they'll say, well, I said, hold on, before you answer, did you really, really want to die? or were you wanting out of pain? Were you wanting out of pain? And I said, think about it for a second. And they'll stop and they go, Miss Janice, I just wanted out of pain. And wow. And I'm like, there's so many other ways to get out of that pain. And so, my heart so strongly is for the body of Christ, for the church, for us to stop being in denial. Remember denial? Y'all know about denial. Denial. Don't even notice I am lying. Denial. And this is what will happen with eating disorders. It happens with addiction. It happens with alcohol, drugs. It happens with pornography. It happens with, got issues in with the child or issues in one's marriage. But God wants us to get honest, because what is, I think it's First Peter 5:8 says that our adversary said, be sober. This is what it says. It says, be sober and be vigilant, because our adversary, the devil, goes around seeking whom he may devour. Jesus said, the thief cometh not but for to steal, kill, and destroy. But I've come that you might have life and have it more abundantly. What will abundant life look like when someone's struggling with an eating disorder? This is her area of expertise. Go to my website, www.janicesponza.com. Click on resources, and you'll be able to go to Dr. Heather Gillam's website, and you can see more what she's talking about. And Rachel has her information up as well, the visual for her website. So these are, I want us to talk about these things. We need to provoke thought. We need to give people permission to get informed, and people to receive and get the intervention that they need, because they don't have to suffer, because God has an amazing plan for our lives. So this whole thing about eating, I mean, we just don't talk about. I mean, when I grew up, you go you go down in the country down there where those old sisters cook the good soul food, honey, they would just cram you with, come on, baby, come on in here, y'all sitting around, yeah, come on. And it's just they just feed you, and that was like, they were proud, they wanted you to eat more. The more you ate, I guess the better they felt, because they had really worked hard and strove. There was a lot of striving to make the most excellent food, and a lot of it, and they wanted you to eat a lot of it, and it became a part of culture. In the Black community, eating, we eat, we eat. And sometimes it's a focus on eating and the fellowship. And sometimes I like to just meet with people and just fellowship, and we're not going to eat. We're going to talk. Let's have some coffee. Let's have some tea. And let's just get to know one another. Sometimes food can be a distraction. I mean, it's okay to go out and eat, but sometimes we just need to not have the food. I remember someone was telling me, they said, we need to sit down somewhere and eat. I mean, we need to sit down somewhere and talk, and we're not eating, because we really need to talk about some serious things here. So these are all things that to think about. So kind of in closing with this, give us some your closing thoughts about how we can maintain balance. Food, we gotta eat.
Yes.
See, with food, that's one of those things where you gotta eat. Yeah. And then you got people with the anorexia. It's like they're restricting. I'm like, they just eating a teaspoon or something, baby. What do you mean a teaspoon? You're not getting any nutrition out of that. So what's the balance?
Well, I think the balance can be different for every person, right? So what our body needs, what I need, what you need, what our family members need, it's going to be different, right? So everybody needs to be doing what they need. But at the end of the day, if there's a sense of awareness, whether it's your own awareness for yourself, or whether it's awareness that something's not right for somebody in your family, a kiddo, a loved one, just the sense of well-being that's there. If there's a question in your mind about whether or not, is this right, is this not, then it's time to kind of ask questions, right? And to start looking for that balance. And what does that look like for me, for my nutrition, for my body, for my health, and the same for our loved ones.
Wow. So questions such as evidenced by, some questions such as what, for example?
Yeah, what should I be eating, right? So there can be answers that specialists can provide, dietitians that can say, here's what's going on. Your doctors can draw blood and say, you're missing this, that, and the other probably in your diet because this is what your blood work is saying.
Oh, wow.
So asking those questions, if you feel like something's not right, ask the questions, right? Find a team, find a psychologist, therapist, dietitian, your physician, and start looking into it. Just look into it and see, and they'll put you on your way.
Awesome. I am so thrilled to have had Dr. Heather Gillum as my first guest. We're going from destruction to dignity. What we've done on the last 2 episodes, we've talked about food. We've talked about the difference between eating disorder and disordered eating. And we've talked about some very specific eating disorders. Listen, these are areas where people need help. We need to empower people and give them permission to go there, because God wants us to go from destruction to dignity. Come back next week for episode 12. We're going to dive into the scapegoat, because God wants us to go from destruction to dignity in that area. He does not want us to be the recipients of irrational hostility towards ourselves. And he definitely does not want us to be emitting and putting out irrational hostility towards others. God bless you. We'll see you next time.
We are God empowered, strength is ours, liberty, been set free, education, affirmation, dedication, information, revelation, a new nation.